Monica Deza. I'm an assistant professor in CUNY-Hunter College, CUNY Graduate Center in MBR. The paper I will present today is Local Access to Mental Health Care in Crime. And this is joint work with Catherine McLean and Keisha Solomon. So first, the purpose of this presentation is to talk about whether mental health care can be a tool to fight violence. So we've all been aware of when we think about tools to fight violence, we think policing, we think incarceration, and yes, they work, but there's all this other realm of policies that are not really intended to fight crime and yet have some effects that are comparable to some extent to criminal justice policies. So at first, what was our motivation for it? So how can mental illness potentially affect crime? Well, we cannot really disentangle the mechanism because it could offend the offender, the victim, and there's also something called criminalization of mental illness. So from the offender's perspective, you can think that if somebody has paranoia and they think that somebody is continuously following them and they're suspicious of everyone, continuously angry about it, they could potentially be more likely to offend and potentially more likely to commit violent offenses. Now, in terms of the victim, they might be an easy target if they draw attention to themselves, if they have some type of they are speaking more loudly, they are speaking more aggressively, they might be more likely to be targeted for violence as well. And then criminalization of mental illness, what I mean by that is that if you have two individuals and they both commit the exact same identical crime, they do commit burglary, but one of them is mentally ill, he or she might be perceived by the police as being more aggressive or might be perceived as being under some type of under the influence, and therefore that person might be more likely to get arrested. So there's several mechanisms through which mental health care could potentially be linked to crime. Also, not to mention, there's a strong association. 50% of those incarcerated have mental illness, and those are just like the diagnosed mental illness. So before we start talking about the paper, I wanted to discuss a little bit of the history of how we always been concerned about the relationship between the mentally ill and violence, or has this been something that has evolved over time? So between the 60s and the 70s, there was the institutionalization movement that came from a vast public support for humane treatment of the mentally ill. So this led to several state psychiatric hospitals to close, and that resulted in the displacement of patients that would have before been in a mental in a psychiatric hospital. Now they'll be displaced to the community. So people will be exposed for the first time to the mentally ill, and they had concerns over whether they impose a threat. At the time, there was limited data that could test empirically whether they were actually a threat. But overall, in the 90s, as crime declined, so did this concern, and people just started being less and less concerned about whether the mentally ill affected crime. So now we go back to the question that we're originally asking. So can mental health care be a tool to fight violence? So first I want to clarify, when we say mental health care, there are several modalities. We're talking here from something as easy as attending a quick meeting with a counselor that will teach you some ways to cope with anger, all the way to being institutionalized for long periods of time in a psychiatric hospital. So which modality of mental health care are we focusing on? So this is the first study that focuses on a non-intensive, light-touch, office-based provider who deliver care in a private practice. So by this, I mean the local psychiatrist and the psychologist. So obviously this is voluntary and on a weekly, bi-weekly basis. It does not take too much time. Is usually like 1 hour appointments. Therefore, incapacitation is not really an issue, which is usually an issue if you're studying other modalities that actually require a longer period of commitment. In terms of the modalities of mental health care, there is a level measure where level 0 is things like prevention, just attending a talk of how you shouldn't be angry. And level 4 is hospitalization. This type of modality that we're studying, office-based, is considered a level 1 modality. So, so how do we complement our study with previous studies? So we complement the studies on other modalities, hospitalizations, hospitalizations. So there's been studies that have already established the effect of mental health care on crime. This study contributes to say, well, there's a vast of modalities and they all seem to actually have an effect of violence. To the extent that different modalities affect different types of patients, that just says that it reduces crime across a wider spectrum of the population. To the extent that it affects different types of modalities that each of them have a different type of cost of attending. It just says that it affects people with different types of treatment adherence. You could think that going to like a full day of treatment is you're less likely to adhere to that treatment than to go into like a 1 hour meeting with a therapist. So overall, several types of mental health care seem to have proven to be an effective tool to fight violence. So this is the method that we use. It's a two-way fixed effect model. Let me show what each is. Okay, so we estimate the effect of, right here, the number of office-based mental health care providers in the county from the previous period. We have the vector of county level characteristics. So there are things like poverty, income, and so on. State by year fixed effects, county fixed effects, and the dependent variable here is crime rate for county I and state S in year T. So we are going to use for this regression just the classic uniform crime report data, which has violent and property. Let's see why this is redoing it. Okay, so the findings in this paper is that increasing access to local mental health care decreases crime. So in particular, we find that 10 additional offices reduce crime by, well, 1.6 incidents per 10,000 residents, reduces violent crime by 0.9 incidents per 10,000 residents, and property crime by 0.7 incidents per 10,000 residents. Now, in terms of what they mean as a percentage, so total crime is at 0.4%, violence at 2%, property is at 0.2%. Note that the decrease of violence is the one that is particularly noticeable here. And that makes sense because mental illness potentially affects the way that somebody responds to a situation. So in particular, well, these 10 additional offices represent an 8% increase in the number of offices. So if we were to compute elasticities here, we will be computing a crime office elasticity of 0.05. So does the magnitude make sense? So remember first that we're not comparing here apples, like something like light touch to something slightly harder. We're comparing a full psychiatric hospital where people stay there against their will for long periods of time versus somebody who just goes to speak to the therapist once a week voluntarily. So think about the compliers will be patients with relatively well-managed mental illness, can be treated in an office-based setting, take up new treatment when office opens nearby, already receiving treatment, but local office allows them for a better match. So these people, whereas people with severe mental illness, they might actually just, in order to function, they might actually have to drive to another county to get their medication if needed. So there are people that only seek care when it's closer to them. The hypothesized channel says like, well, increase access to mental health care, more people seeing mental health care providers, mental health improves, less crime. And so far I've shown you the less crime part, but what about this too? Well, for more people seeing mental health care providers, we find evidence that there's an increase in Google searches for mental health care providers when there's more offices in the neighborhood. There's also a decrease in suicide rates, and there's a decrease in reporting any mental illness. So there is some evidence that mental health is actually improving and that people are actually trying to seek this type of healthcare. Now, in terms of a policy takeaway, so there's unintended benefits from expanding office-based mental health care workforce. So in our paper, we find that an additional 10 offices will decrease crime rate by 0.4%. The social cost of decreasing crime, well, deterring one homicide is very different from deterring one incident of shoplifting in terms of how much social cost is this costing. So if instead of looking at crime rate as incidents, which will count one homicide versus one robbery, we estimate the expected cost of crime, we'll find that additional 10 offices decrease the cost of crime rate by 2.2%. And this is more in line with the violent crimes because they are usually the ones that are dropping the cost. This complements studies that focus on other modalities of mental health care. So modalities that are more intensive, residential, and even cognitive behavioral therapy for youth, as the paper by Sarah Heller. Given the high cost of traditional costs to fight crime, like I'm talking about policing, incarceration, it might be worth to wait this other potentially less costly modalities that could actually decrease crime and that they may actually be to some extent comparable. So those are my policy takeaways, and I think I'm on time.